This court's now in session. Be seated, please.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant and including the 18 jurors.
All right, thank you. Commonwealth, call your next witness, please.
Your Honor, Commonwealth would call Rochelle Amity.
Watch your step, please.
Hey, good morning.
Good morning.
Inquire?
Yes, counsel, please.
Thank you. Good morning.
Morning.
Could you please tell the jurors your first and last name?
Rochelle Amity.
Do you mind spelling your first name for the record?
Rachelle. Last name is Amede.
Thank you. And how are you employed? What do you do for work?
I'm a nurse at Brigham and Women's Hospital, the trauma surgical ICU.
How long have you been a nurse?
Almost 27 years.
And can you tell us a little bit about your educational background?
I have a bachelor's in nursing from Salem State University.
And how long have you worked at Brigham and Women's?
20 years this week.
And which unit did you say you worked in?
The trauma surgical ICU.
How long have you worked in that unit at Brigham?
8 years.
Going back to January of 2023, were you working in that same unit?
Yes.
And what was the shift that you normally worked?
I work the night shift, which is 7 p.m. to 7 a.m.
And what was your schedule like for any given week? Did you work back-to-back shifts or?
I can sometimes work back-to-back shifts.
Okay, but you always worked the night shift?
The night shift.
Okay. I'm going to draw your attention to a particular patient that you had some interaction with in January of 2023, and that was Lindsay Clancy. Do you recall treating her?
Yes.
And was she in that trauma surgical intensive care unit?
Yes.
Do you remember the first time you interacted with her?
Yes, I got her.
And would that have been on the first night she was there on January 24th?
Yes.
How did she come to your unit at the Brigham?
She came from the emergency room, went to MRI, then came to the ICU to me.
And were you aware that she had been seen at a local hospital?
Yes.
In Weymouth, the South Shore Hospital?
South Shore.
While you were treating her on that first night, were you the main nurse assigned to her care?
Yes.
And what were your responsibilities as the nurse assigned to her care on that first night?
First night, she was intubated, came to me intubated. We had to maintain her blood pressure at a certain number, just care, regular nursing care.
Okay, and were you aware that she was on what's called a 1-to-1?
Yes.
What does that mean?
That means patient usually can't be left alone, and also depending, you always have to have somebody outside the room to monitor the patient.
And is that because that patient has been identified as a potential suicide risk?
Yes.
Okay. Now, on that, the 24th into the early morning hours of the 25th, was there a particular event that you were witness to for this particular patient?
She coded.
What does that mean?
Means her blood pressure dropped for her. It meant her blood pressure dropped and it wasn't sustainable with life.
So what did you do when her blood pressure fell and she coded?
We started CPR, we did compressions.
And this event occurred approximately at 3:30 in the morning, correct?
Yes.
Was she eventually stabilized after that code?
She was.
And did they do something as far as intervention to try to maintain her blood pressure?
We increased her pressors. We added 2 more pressors. She was already on 2. They placed chest tubes in, started what we call a massive blood transfusion protocol.
And did this all occur in the trauma surgical intensive care unit, or did she have to be taken to a different unit?
No, it all occurred in her room.
And other than medical staff that was treating her that particular night, did you observe anybody else present?
She had 2 police officers outside the room.
Okay, and so did they remain outside the room for the duration?
Always outside the room, yes.
As far as your interaction with the patient on that particular night shift, was she responsive at all during the time that you saw her?
No.
And with intubation, you mentioned she was intubated. Is a patient often sedated in order to maintain intubation?
Yes.
Why is that?
Helps them not fight the vent, breathe better, and make sure that they're comfortable.
And what does sedation do to an individual?
You're calmer, you're sleeping.
Makes them more relaxed?
Relaxed, yeah.
Other than that night, that first night, the 24th into the 25th, did you have the occasion to treat this patient at other points within that week?
Yes, I have.
And I'm going to draw your attention to January 26th of 2023. Do you recall interacting with her on that day?
Yes.
And is it fair to say that on the 26th she was still intubated?
She was.
And under sedation?
Yes.
But during this time period on the 26th, was she arousable, meaning could you initiate some communication with her?
Some, yes.
And were you able to kind of give her commands in order to care for her that she was able to follow?
Yes.
And when I say able to follow, obviously...
Simple, commands.
What kinds of
Like, can you
commands?
squeeze my hand? Can you wiggle your toes? Just basic neuro check to just make sure she's alert and she's able to follow, understand what you're saying to her.
And for this particular patient, you're aware that she presented with a spinal injury, correct?
Correct.
And so movement of the lower extremities was not something that she did?
Correct.
But did you observe her to move her head around and move her arms around?
Yes.
Now, you also had the occasion to treat her in the overnight shift of January 28th of 2023, correct?
Yes.
And during that time, she was also still intubated?
I believe so. I'm not sure. I've had her both intubated and
Okay.
extubated.
While she was still intubated, did you have a system that you could use to communicate with her?
Yes, board. We have a whiteboard or clipboard that sometimes patients can write on.
Did you observe her to utilize that whiteboard to write on it?
Yes.
And at this point, when she's writing on the board, her eyes are open and she's responsive.
Yes.
And she's able to tell you how she's feeling, correct?
Yes.
And fair to say she used that whiteboard to tell you she was confused and that she couldn't feel her lower extremities.
Yes.
And do you recall her complaining of having pain?
I don't recall.
During this time period on the 28th, do you recall whether the patient was placed into restraints?
Yes.
And why was that?
Well, we restrain all patients that are intubated for safety,
And why?
so they don't pull out the tube or pull out any lines that they have.
Okay, and so as they're not at that level of sedation anymore where they're just completely asleep, there is danger that they could move and cause damage to...
Medical equipment out of the way.
Okay. And so in this case, as far as the restraints go, fair to say that they were soft restraints.
Soft, yeah.
And what does that look like for a patient?
Meaning
Well, like how do you... What does a soft restraint look like?
a soft restraint, it's like maybe I would say a cushion restraint, and then it's tied to the sides of the bed. So it's all the way around your wrist.
Okay. At some point by the end of that shift, you recall that she was extubated.
Yes.
Can you tell us what extubation is?
That means you remove the tube. You usually stop all sedation.
And were you able to make observations of the patient once she was extubated?
Yes.
Did her presentation change at all from your previous interactions with her?
No.
Did you have the occasion to treat her again on January 30th?
Yes.
And again, at that point, she has already been extubated. And are you able to then make an assessment of her without the tube in about her orientation and her alertness?
Yes.
Is that something that you kind of do each and every shift?
Every shift, yeah.
Was she still on sedation medication at that time?
No.
And what was your observations of the patient's demeanor now that she is extubated?
She's flat. No emotion either way.
And is that fairly consistent with what your observations were of her during the course of your time treating her?
Yes.
How about being alert and oriented? Did you observe her to be alert and oriented?
She was.
And did you observe her to identify sleep as an ongoing issue?
Yes.
And so as part of the plan for treating her, did you address the sleep?
Yes.
And how did you guys address sleep?
The plan was to start the first sleeping medication for her. I don't remember exactly which one, and then wait a couple hours, see if it worked, and if not, try another medication.
Okay, and this actually occurred over the course of a few days,
Few
correct?
days. Yeah.
During the time when you observed her to be flat, as far as her affect goes, did you also observe her to be cooperative?
Yes.
Meaning she followed your directions?
Yes.
Did you treat her, or were you the overnight nurse for her on February 2nd? You recall?
Yes.
On this particular night, February 2nd, do you remember her making a particular request of you or ask you for something specific?
I think that was the night she wanted to reach out to her lawyer.
And did you note that in your nursing notes?
Yes.
And why did you note that particular request?
Objection.
Could I see counsel? Yep, counsel, go ahead.
Thank you. So on this particular night, the 2nd, she made a request of you for her lawyer, correct?
Yes.
Was that something she had asked you before?
No.
And so did you think it was something worth noting?
Yes.
Why would you note something like that?
Because that was the first time she referred to anything going on with the case. Or whatever.
Okay, and so you had the occasion after she was extubated to have some casual conversation with her, correct?
Yes.
Okay. And this was not a conversation you'd had before?
No.
What did you do when she made that request? What was your response?
I sent what we call a consult to the social worker in order to coordinate reaching out to her lawyer.
Okay. In any of the shifts that you had been caring for this particular patient, did you see anyone besides medical staff and the law enforcement that were outside of the room come in and speak with her?
No.
Were you aware that she was not to have visitors?
Yes. I was told the first night.
And is that something that you've seen before in your work as a nurse when there are police on site?
Yes.
Were you present at one point when some troopers came in to take photographs of her?
Yes.
And were you in the room when they took the photographs?
Yes.
Do you recall assisting them in viewing the injuries to her wrists and her neck?
I don't know if I don't remember assisting.
Okay, but you were present.
I was present, like, in the room with her.
And fair to say, your contact ended with this patient on February 3rd when she was transferred off of the trauma surgical ICU unit.
Yes.
So, one moment.
Sure.
Now, you were not the only nurse to treat her on the night shift, correct?
Correct.
So on days that you didn't work, another nurse treated her?
Exactly.
And were you familiar with the nurse who was generally assigned to treat her during the day?
Yes.
And who was that?
Megan Collins.
Megan Collins. And is it fair to say that with the law enforcement presence and this patient's particular situation, the amount of medical staff that were treating her on a regular basis was fairly limited?
Correct.
Meaning it was the same
Yes.
people all the time? Okay, thank you.
All right. Attorney Reddington.
Morning.
Morning.
So first of all, you have the certified copies of the records from Brigham and Women's Hospital. I'd like copies.
All right. Commonwealth, any objection?
I actually have those on a disc. I was going to put the disc in instead of all the paper.
Why don't we put both in?
Sure.
We could do A and B.
Thank you.
Now let's talk about a lawyer first, since that was the last that they asked you about. And correct me if I'm wrong on any of these dates or facts. She was admitted on the 24th of January. Is that correct?
Yes.
And do you have a memory as to approximately what time was it in the evening?
Well, she got to the ICU, it was around 3.
Okay. You're very soft-spoken.
Sorry.
You can just keep your voice up so all the jurors can hear you.
She got to the ICU around 3 a.m.
Thank you. And she came by med flight?
She came to me from MRI.
And MRI obviously would be when you're taking the pictures.
Picture,
And that would be on the 24th of January in the early morning hours, correct?
I think it went into the 25th.
Into the 25th?
I think so.
Counsel asked you about the whiteboard that she would write on. And I think it was, again, if I'm wrong, correct me, was it January 28th that she used for the first time the whiteboard to communicate?
Yes.
And the whiteboard basically is just a whiteboard, and,
Yeah.
and you write on it. Is that correct?
Erasable.
And she was not able to speak because she was intubated, right?
Yes.
And she was in the restraints that you've described as well, right?
Right.
Moving forward, January 28, 29, 30, into February 1st, February 2nd. It was on February 2nd that counsel asked you about her asking to reach out to her lawyer, correct?
Yes.
And do you know who her lawyer was at that time?
No.
Had you seen him before?
No.
Did you know, is his name Attorney Gelb?
No.
Make any reference to you?
No.
Do you know that whether or not she had conversation with Attorney Gelb regarding her status as being under arrest by the numerous police that were guarding the room?
I don't.
Do you know whether or not she was ever able to talk to Attorney Gelb, or did you refer her to the social worker people?
I put in a consult for the social worker.
Okay, thank you. When she was admitted on the 24th, would you agree that she was in the state of cardiac arrest shortly thereafter?
Shortly after arriving to me.
So I'm looking at the medical records that have been introduced for the jurors, and I'm referencing on page 18, if I may, Now, this is one page of 400 pages of medical records.
Can you see that?
But
All right, here we go.
looking at this, does it indicate it's an SICU course?
Surgical ICU.
I'm sorry?
Surgical ICU.
Okay. And that makes reference to the fact that shortly after arriving in the ICU, the patient had a cardiac arrest. Is that fair?
Yes,
Were you there then?
I was.
And when it says the etiology of the arrest, she got 2 rounds of CPR before obtaining ROSC. Can you tell me, please, what is CPR at 2 rounds and what is ROSC?
Meaning we did chest compression. She was already intubated, so she was getting oxygen.
Okay. And then bilateral chest tubes were placed in her body?
Yes,
Does that mean from both sides?
both sides.
Okay. And that punctures through the chest into what, the lungs?
The lungs.
Okay, the lungs. And when they placed the chest tubes, at this point, shortly after admission, there was 100 to 300 cc's of blood from each chest tube? What does that mean?
That's the output they got once they put the chest
Sorry,
tube.
again, just can you keep your voice?
That's the output they got once they put the chest tube in?
Okay. So when they put the chest tube in, it drained 100 to 300 cc's of blood. Is that correct?
Correct.
And then after that, again, shortly after admission to the hospital, coming from South Shore Hospital, she then got a massive transfusion protocol, which you told us about, right?
Yes.
And what does that mean?
Means she gets, we have a protocol that with blood, depending, blood products,
Okay.
she gets infused rapidly.
And was there a notice shortly after arrival to the ICU, she was being turned and had 30 cc's of clear fluid that came out of her nose. Is that right?
Yes.
And what is that? Was there a suspicion that that was what's called CSF?
Yes.
And what is CSF?
It's spinal fluid.
Okay. Going to the next page, which would be 19, does it indicate, again, on there, if I can just bring this up a little bit better. So she now has noted acute blood loss, anemia, right? What does that mean?
She has a low blood count.
And do you know what happened to the blood or any idea?
I do not.
So she had very low, lost a lot of blood, right?
Yes.
And she had anemia. That would be what, low blood or something?
Yes.
And she required multiple transfusions immediately following her arrest, right?
Yes.
And when it says arrest, does that mean arrest by the police or does that mean the cardiac?
Cardiac.
I want to make sure that's clear. It's cardiac arrest, nothing to do with the police, okay. And she had required multiple transfusions. And you were there for that, correct?
Yes.
Were you aware of the extent of after you had the after you had the MRIs and the CAT scans, were you aware as the lead nurse or treating nurse as to what the extent of her injuries were?
At that point, I don't believe so.
All right. At some point, did you become aware of that?
Yes.
Okay. So, and again, I've got the records. You don't. So let me do it this way, just to make it easy. Do you remember that she had a burst fracture of C1?
Yes.
What does that mean?
Means a cerebral fracture.
That'll be up here. So this is the cervical spine
Cervical.
up here.
Mm-hmm.
And then T5 and T6, there was a
Thoracic.
transection. What does that mean?
Thoracic.
Okay, so
On the
that'd be about
spine.
down here. And when it says transection, what does that mean?
It's severed.
And then T1, 2, 3, 4 also were injured as well, right?
Mm-hmm.
What is neurogenic shock? What does that mean? If you know.
Neurogenic shock.
Sorry, yeah, neurogenic shock. It just makes reference on,
These are not my notes, so I can't really.
that's fine, I understand. And this would be on page 65. Do you recall reviewing the documentation as to what's captioned present illness in the records? Did you know that she was presenting as a transfer from South Shore Hospital?
Yes.
Did you know that that under present illness and the history would be that she's a 32-year-old female with history significant for postpartum depression? Did you know that?
Yes.
And did you know that after the fall with the C1 burst fracture and the complex transection of T5 and T6, she also had rib fracture, correct?
Yes.
On page 66, that would make reference to the time frame going into the 25th, on the 25th, that she was reacting to painful stimuli, right?
Yes.
And that basically means that she's not conscious, if you will, but she's able to react to...
If you cause pain.
Yeah. Okay. There's a notation of a contusion, laceration, and crushing of the thyroid with thyroidal edema. What does that mean?
She has swelling, I'm assuming, around her thyroid.
Okay, and that is...
Again, this is not my scope
Okay.
of practice, so.
Okay. On page 70, the same evening, making reference to the fact that in addition to the injuries to the spine, that she also had the rib fractures and was currently in shock. Do you remember that she was in shock? Yes, no?
Yes.
Okay. Would you agree, or do you recall that there's a notation that this patient is critically ill, and noting that she has postpartum psychosis on page 72?
Objection.
I see counsel.
When you're treating a patient, one of the things you try to do is to know what their total body and emotional condition is, what they've been dealing with, and what injuries they have, right?
We get a rundown or history of the patient.
Sure. And as it goes into the end of January, and she had been communicating on the whiteboard, you were aware at that point why she was in the hospital, right?
Yes.
You knew where she came from, South Shore Hospital, right?
Yes.
And you knew that there had been discussion about postpartum psychosis. Isn't that right?
Yes.
Okay. And do you recall that, and this would be on, may I approach you, Honor, the witness?
You may.
Thank you.
You can maybe, if you could show counsel. Wait.
I want the date and the time. And the lawyer, legal team. So I'm just showing you one page from the medical record. Can you tell me in terms of what date is this page from?
125.
January 25.
If I'd ask you if you keep your voice, at least speak in the
Oh, sorry. Yeah.
Thank you.
January 25th,
Okay, does it say what time?
9 a.m., 9:03 a.m.
All right, can I see that for a second? Thank you. And looking at that, do you recall on that date, you had been working with her the night before, correct?
Correct.
Where it indicates that the patient is under arrest, right?
Yes.
And there are police officers at her bedside. Right?
Outside the room,
Well, it says at her bedside on the record, doesn't it?
in the record, but I'm saying
So
they
the night before,
were outside her room.
outside the room. You were not there during the day, apparently, right?
Correct.
Okay. And there's a difference from you guys as far as your medical records. If the police officer is at the bedside as opposed to sitting in a chair in the hallway outside the room. Right?
Yes.
Okay. So indicating police officer at her bedside, we will involve the social work and legal teams, right?
Yes.
Okay. And again, on page 72, there's a reference to CSF leak, and that's significant. It says significant amount of fluid coming from her nose. Do you have any memory of observing that in your treatment?
I did.
Okay. And then, of course, there was the code event that you've already described for us. There's the 100 to 300 cc's of blood coming from the tubes, and then it makes reference to, on page 74, to massive transfusion protocol. Is that like a medical term, or is that somebody
Yes,
describing it, or?
It's a medical, like it's a protocol that we have at the hospital.
Okay. And on page 75, did you make reference to, or did you observe the injuries, for example, to her wrist?
I observed.
Yes. And would you agree with me, page 75 of the medical record, indicating if it says RUE, what does RUE mean? Do you know?
Oh, right upper extremity.
Right upper extremity, 3.5 centimeter deep laceration, volar aspect of wrist. Can you tell me what is the volar aspect of the wrist? I just don't know.
I'm not sure what
Okay,
that's
that's all right.
referring to.
That's fine. Would you agree that there was noted a 3.5 centimeter deep laceration on her wrist?
I can't say because I didn't measure. This is somebody else's note, so.
Well, when you looked at her, did you observe with your own eyes and your own experience that she had a deep laceration on the...
She had a laceration, yes.
You can't say it's deep or not?
I can't say. I didn't.
You want to say it was superficial?
I can't say that either.
So when you looked at the laceration on her wrist, you can't tell us if you would agree that it was a deep laceration.
I really didn't get to assess it at the time when she arrived. So.
LUE, underneath that, left upper extremity apparently, right?
Yes.
2-centimeter deep laceration, again, on the volar aspect of the wrist. You did see laceration on her left wrist?
Yeah, she had dressings.
Okay. And when she was admitted, she had the core temperature of 82 degrees. Is that correct?
If that's what's noted.
All right. Do you remember, did they use a bear claw or something like that? What is it they call it? They put
A bear hugger?
bear hugger. They put a bear hugger blanket on them. And when I say them, I mean people that have a low,
Low temperature to warm them up.
it hopefully raises the temp, right?
Temperature, yeah.
And then if it has warm intravenous IVF, that would be putting warm saline in the body?
Yes, through an IV.
All right, all with an effort to try to get the temperature up, right?
Yeah.
And her core temperature was 82 degrees even after she was at the South Shore Hospital and underneath the bear thing and all that, and still?
If that's what's noted.
Yeah.
Again, that's not my note.
That's pretty low, isn't it?
It is.
And you made reference to pressors. I'm sorry, can you tell me?
Pressors,
What's
blood
a
pressure medication to bring up the blood pressure.
Okay. On January 26th, she was still intubated, is that right?
Yes,
And she was under sedation, right?
yes,
And then you referenced January 28th overnight shift, she was still intubated, right?
yes,
And January 28th is when she first started utilizing the whiteboard, is that correct?
yes,
But she was intubated, yes?
yes,
She was restrained to the bed,
yes,
and had the tube was still in her mouth, and she was writing on a whiteboard on the 28th of January, correct?
she was able to, yes,
January 30th, she was extubated, as the district attorney asked you, right?
yes.
So at that point, was she able to talk, talk?
Talk.
Okay. And then on February 2nd is when she used she asked about wanting to reach out to her attorney. Is that correct?
Yes,
But you had no knowledge as to her mother and father getting an attorney for her while she was in custody with the police all around her?
no,
Okay. And you tried to help her out as best you could?
yeah,
right?
to coordinate. It's harder at night to,
Sure.
so I wanted to pass it on.
And finally, she was not able to have visitors per order of the police. Is that correct?
Correct.
Thank you very much, ma'am.
Thank you.
Como, redirect.
Ms. Amity, the first time that Ms. Clancy, the defendant, the patient, used a whiteboard with you was on January 28th, correct?
Yes.
You're not aware of if she used that tool with other nurses on other shifts,
No.
were you?
No.
And the first time that she mentioned a lawyer on the February 2nd, that's the first time she mentioned a lawyer to you, correct?
Correct.
You were asked about the trauma in the chest tube and that she lost 100 to 300 cc's of blood.
Yes.
The transfusion came after that, correct?
Yes.
And fair to say the course of her treatment coming to Brigham was that she first came in through the emergency department, correct?
Yes.
Then she was sent for an MRI,
Yes.
and then she came to the trauma surgery, correct?
Yes.
And you're aware that she had other imaging like CT scans, correct?
Yes.
And that especially when it came to the head CTs, she didn't have any intracranial injuries or anything that required that you be focused on her head injury, correct?
Correct.
So it was more a cardiac issue and keeping her stable and internal bleeding in the chest area.
Yes.
As far as what you're aware of from other treating physicians, you're aware Dr. Anderson was one of the trauma surgeons that was treating the patient,
Yes.
and he was making assessments and giving orders to you and other nurses, fair to
Yes.
say? And are you aware that he identified in the history that this patient actually had a history of postpartum mood symptoms, not psychosis?
I would have to look at the note. I don't remember.
Those aren't notes that you would have written?
No,
And you weren't taking a full history of the patient?
not at the time, no.
Were you aware that she then subsequently was fully evaluated by the psychiatric team?
I knew she saw psych, yes.
And were you aware that they ultimately identified that there's an inherent uncertainty in her diagnosis?
I do not remember.
As far as the lacerations went, in your treatment of her, again, you treated her overnight shifts for various days, correct?
Yes.
Did you ever have a situation where you had to change her bandages because they were seeping?
No,
And are you aware that
except for the first night, but we didn't get to that because she coded.
because she coded? And then you're aware that the next day after, another individual, a physician's assistant, actually came in and treated those lacerations.
Sutured, yeah.
And as far as Dr. Anderson goes, were you aware that on January 25th, he noted that the lacerations to her neck and wrists were very superficial and didn't require treatment at that time?
I was not aware. Don't remember that note.
Would you, if I showed you the record that's in his note, would you agree that that's an assessment that he made?
Yes.
Okay. And he didn't instruct you to do anything further with those injuries?
Yes, right.
Thank you.
Very briefly.
Sure.
District Attorney asked you about the evaluation by the, as she put it, psychiatric teams with a determination that there was inherent uncertainty according to the psychiatric teams. Do you know when the psychiatric teams were evaluating her?
I don't know. It was during the day. I don't know what day, but.
But in any event, I did show you on the thing over there where the reference was made to postpartum depression, postpartum psychosis, correct?
Yes.
And that's all I have. Thank you, ma'am.
Anything further?
No, thank you.
All right, thank you, ma'am. Let me sit down. Thank you. All right, Como.
The Commonwealth would call Megan Collins.
Watch your step, please.
Hi, good afternoon.
Hi.
Ask you to speak into that microphone, keep your voice up.
Okay.
All right. Attorney Buckingham, please.
Thank you. Good afternoon.
Hi.
Can you please tell the jury your first and last name?
Megan Collins,
Would you mind spelling your first name for the record?
Meghan.
And-
Collins, Collins.
Thank you. And what do you do for work?
I'm an ICU nurse.
And how long have you been a nurse?
11 years.
And did you go to school for that?
Yes.
Where'd you go?
Sacred Heart,
What hospital do you currently work at?
Brigham and Women's.
And how long have you worked there?
8 years.
In January of 2023, what unit were you working on at the Brigham?
The trauma surgical ICU.
Did you work a particular shift?
I did.
And what shift was that?
7A to 7P.
So 7 a.m. to 7 p.m.? And you just have to answer out loud, sorry.
Okay, yes.
I'm going to draw your attention to a particular patient that was treated there beginning on January 24th, Lindsay Clancy. Are you familiar with that patient?
Yes.
Were you a nurse that was treating her during the day shift while she was in the ICU?
I was.
Are you aware that she arrived at that Brigham Hospital on January 24th of 2023?
When she was admitted to our ICU, it was overnight.
So as far as the hospital, do you know when she arrived at the hospital?
I believe the evening prior.
And you, a patient who comes to your hospital doesn't automatically come to the ICU, correct?
That's correct.
Where do they go first, usually?
The emergency room.
And you're aware this particular patient actually went through a local hospital before being transferred to the emergency department at Brigham and then to the ICU, correct?
Correct.
And so when you interacted with her, she had already been at the ICU unit for that night shift. Is that fair to say?
Correct. Interacted. She was intubated when she arrived.
And were you with her the entire day of the 25th from that 7 a.m. to 7 p.m. shift?
Yes.
And was she on what's called the one-to-one during that day?
Yes.
And what does that mean for you as the nurse if she's on the one-to-one?
She was one-to-one nursing per our ratios because of how critically ill she was.
And so you were there pretty much the entire time?
Correct.
Were there any other people there other than the medical staff and yourself treating her? Were there any other people there?
There were officers, police officers.
And they were outside the room?
Correct.
Had you taken over care of this patient from another nurse on the night shift?
Yes.
And who was that?
Rochelle?
And you are familiar with Rochelle? You've worked with her before?
Yes, I have.
And were you advised that over the course of the night shift that this patient had coded?
I was.
And when you came on shift in the morning, because of what had happened overnight, were you aware that she was sent for additional CT scans?
We went for CT imaging in the morning when I got there because she was not stable overnight.
Okay. And you said she was intubated, correct?
Correct.
How about, was she responsive during that first day that you encountered her?
The first shift that I had her, we were focused on her injuries and keeping her sedated, so the interactions, responses were minimal, but that was intentional as she was, again, like I said, so critically ill.
And so you also said that she was sedated for the majority of that day, correct?
Yes.
And is that something that often happens when a person is intubated, that they're sedated?
It is.
What happens if an individual isn't under sedation and they're intubated?
It is patient dependent, but majority of patients are not able to tolerate the breathing tube and it's uncomfortable. So we give them medications to keep them as comfortable in tolerating the breathing tube as possible.
Now you mentioned treating injuries and keeping the patient stable as your primary goal, correct? Were you able to make note of some physical injuries that the patient had?
Yes.
And were there some obvious injuries that you could observe?
Yes.
To her neck and wrist area?
Correct.
May I approach the witness? Just going to show you two photographs, okay? Does that look familiar to you? Mm-hmm. Do you know
Yes.
that to be the patient, Lindsay Clancy?
I do.
And fair to say she has a breathing tube?
She does.
And then the second one, again, just the other side of her neck. Is that familiar to you?
Yes.
Are these very inaccurate representations of the neck injury that you observed for this particular patient?
To the best of my memory, yes.
All right, they may be admitted.
142 and 143.
I'm going to show you on the screen what's been marked as Exhibit 142 and 143. And you said that's, to the best of your memory, what the injuries on her neck look like, correct?
That's correct.
And during your treatment of her, did those injuries require constant attention?
They required dressing changes. It did not require constant attention. She had multiple injuries.
So fair to say she had more significant spinal injuries and other issues that you were working to stabilize her on, correct?
Correct.
Now, you treated her on the 25th, right? And did you treat her on the 26th? To your best of your memory?
I would have to go back and look.
I don't have a problem if she leads her with records, if she has them.
As far as January 26th on that 7 a.m. to 7 p.m. shift, do you recall making notes that the patient required additional sedation due to the tube intolerance?
Yes,
Okay. And that she was started on low dose of propofol?
that is correct.
And that in the afternoon that she had chest tubes and you kind of checked those chest tubes to, it says, interval CXR looked okay with chest tubes to water seal.
Yes, that's correct.
And so she had previously been given chest tubes and your role was just to kind of make sure that everything was fine.
They placed bilateral chest tubes, and monitoring those is a part of my responsibilities in the ICU, and we were concerned for her respiratory status, so that is why I made a note of it.
Okay. And as far as the injuries that were a part of your assessment of her, fair to say on January 29th, you also were treating her that day from 7 a.m. to 7 p.m., and you made a note where you identified injuries, right?
Correct.
And those injuries would have been things that were reported to you based on a doctor's review of labs and images and that kind of thing, correct?
Yes.
You don't make your own assessment about thoracic injuries or cervical injuries.
I do not diagnose.
Also on the 29th or the 28th into the 29th, that is at that point when the patient was extubated, correct?
Correct.
Do you recall making observations of the patient when after she was extubated?
She was not extubated on my shift. I was there the following day.
Okay. Did you note how her demeanor, her presentation the next day?
I did.
And fair to say you noted increased confusion, agitation, and picking at lines and drains, correct?
That's correct.
And fair to say the patient had to be restrained because of the activity.
That is correct.
Is that something that you often see when patients come out of intubation, that when they're extubated that they exhibit signs of confusion or delirium?
Yes, it's called ICU delirium.
And over the course of the next few days in your interactions with her, did you see that delirium decline or decrease?
Yes, it was a multimodal approach to manage the delirium, agitation, and it did get better and it did improve.
And fair to say during the time that you were treating this particular patient, there was also sleep issues that were part of the treatment plan.
That is correct.
And on January 29th and January 30th of 2023, were you present when the psych consult team came in to speak with the defendant?
Yes, I was.
Okay. What was the purpose of you being present?
The purpose is we had consulted the psychiatry team to evaluate and determine capacity, and my role is as the ICU nurse is advocacy on behalf of the patient and to alert the providers if there's any changes in the mental status.
Now, when they came in and you said advocate for their position, you're aware that the patient was looking to change her healthcare proxy, correct?
The patient was changing her healthcare proxy. That is correct.
And that there has to be an evaluation to determine whether she's of a particular mental status and medically able to make that decision on her own. Is that fair to say?
Yes.
And do you recall who was present other than yourself and the psych doctors, the doctors from the psychiatric unit?
There was the social worker, myself, and her lawyer was present.
Had you been present when a lawyer or somebody else was with her prior to this consult?
No.
And fair to say, you were made aware very early on that there was a particular group of people that would be having access to this individual, correct?
Can you clarify?
Well, is it fair to say that the treatment team was kept small on purpose? Meaning the same people were coming in and being the nurse, day and night staff. There was limited access. Is that fair to say?
It was kept to it was kept to a smaller team, but that was also protection of privacy for the patient.
And during the course of time when she's on the ICU, which is between the 24th to February 3rd, there's always law enforcement posted outside the room, correct?
Yes, and it was because she was...
Well, I'm just asking you if there were law enforcement.
There was.
Okay. Do you recall having to check with the nursing director and the legal team at the hospital to make sure that it was permissible to allow anyone in besides medical staff?
Yes, that's standard protocol.
And when she was transferred off of the your unit on February 3rd, did you have any further contact with her?
I did not.
I have nothing further, thank you.
All right. Attorney Reddington.
Afternoon, I think. Yeah. How many years you been a nurse?
11.
And you obviously take that position as very serious, and your concern is to protect your patient, is that right?
That is.
You made reference to the fact that she was changing her her documents as far as healthcare proxy.
Yes.
Did you know anything? Did you know who she was changing it from, her husband to her mother and father, or did you know anything about the specifics?
She was changing it from Patrick to her parents.
Thank you. And finally, what is a DNR?
DNR means do not resuscitate.
Do you know what her DNR was?
Her code status was full at the time that I took care of her.
Do you recall that she had indicated repeatedly that she wanted a DNR, that she did not want to be resuscitated if emergency arose?
I was not privy to that knowledge.
Okay, but that's noted in the medical record. It would be noted in the records, right?
It would be, yes.
Thank you very much.
Thank you.
Attorney Buckingham.
No, nothing further, thank
All right.
you.
Thank you. Please
Thank
sit down.
you.
Thank you.
Commonwealth calls Dr. Shah.
Afternoon, you solemnly swear that the testimony and the evidence you shall give to the court and the jury in the matter now brought in the Commonwealth will testify that I shall be the truth, the whole truth, and nothing but the truth, so help me God. Thank you. Have a seat.
All right. Good afternoon, doctor.
Hi.
I'm I'm going to ask you to keep your voice up and speak into that microphone, all right?
Thanks, Your Honor.
Thank you.
Thank you, Your Honor. Good afternoon. Can you please state and spell your name for the record?
Sure. My first name is Sejal, S-E-J-A-L. Last name is Shah, S-H-A-H.
What's your date of birth?
5/8/81.
What do you do for a living?
I'm a psychiatrist.
And can you briefly describe your education and training background that qualifies you to be a psychiatrist?
Yeah, absolutely. So I did my undergraduate in Philadelphia at the University of Pennsylvania, followed by medical school at Jefferson Medical College, also in Philadelphia. I moved up to Boston to do my residency in psychiatry at Brigham and Women's Hospital and Beth Israel Deaconess, followed by a fellowship in consultation liaison psychiatry at Brigham and Women's Hospital, and then stayed on as a faculty member.
And where do you work currently?
I work at Brigham and Women's Hospital.
And what is your role there?
I'm Associate Chief of the Division of Psychiatry and Medicine, leading the consultation liaison psychiatry service at Brigham.
And what is the consultation and liaison service?
Yeah, so consultation liaison psychiatry is a subspecialty of psychiatry that works at the interface of psychiatry and medicine. So we work both in the inpatient and outpatient settings. In this particular instance, we get called by other healthcare providers that may need help with their patients or have a question related in the psychiatric realm. And so I would see a patient that's admitted to the hospital and help provide recommendations to the physicians and the rest of the care team that's caring for that patient.
So basically, say at the Brigham, if a patient's being treated there and a medical doctor is treating them and thinks that they need a consultation with a psychiatrist, your department would be called.
That's correct.
Okay. And how long have you been with the Brigham?
19 years.
Now, I want to direct your attention to January of 2023. Did you interact with a patient named Lindsay Clancy?
I did.
And was that on January 29th, 2023?
Yes, that was the first of a handful of times that I saw her.
And why did you meet with Lindsay Clancy on January 29th, 2023?
So my team was seeing Ms. Clancy for a number of reasons, including for psychiatric safety risk assessment. She had come in reporting a suicide attempt, which is a common reason why my team would be called, is to continue to ensure that patients are safe when they're in the hospital. So we make recommendations about kind of safety status, what can we do to help keep a patient safe, but then we also make recommendations related to medications. So that's why my team was following her. So that was one of the reasons why I saw her on the 29th, is to continue that assessment. I was also called to ask I was asked a new question that day, a consult question on whether she was able to make the decision to change her healthcare proxy from her, at the time, husband to her parents.
And when you consult to help determine whether someone's capable of making a decision like that, changing their healthcare proxy, are you evaluating their medical decision-making capacity?
That's correct.
Okay. How do you go about doing that?
So there's generally 4 parts to medical decision-making capacity. The first is whether somebody's able to voice a choice and whether that choice is consistent over time. The second is whether they understand the situation under which they're making that choice. The third part is appreciation of the risks and benefits. And the fourth part is kind of being able to reason or rationalize that information to be able to come to a choice and how they came to that choice.
Now, if you're doing this evaluation to determine someone's capacity to make decisions, would a traumatic brain injury factor into that evaluation?
It could.
When you evaluated Lindsay Clancy, was she able to voice a choice to you about who she wanted to be her healthcare proxy?
Yes.
And is she speaking to you or writing this down?
She's speaking.
Speaking. So she's already been extubated at that point?
That's correct.
And she's speaking to you, and were you aware that Patrick Clancy was her healthcare proxy?
I was told that by her primary medical team.
Okay. And when you talked to Ms. Clancy, did she tell you who she wanted to take over that role?
She did.
And who was that?
Both her parents.
And you talked about that needing to be a consistent choice. How did you ensure that was a consistent choice with her?
Yeah, so we waited to make the change from Patrick Clancy to her parents until the next day for a variety of reasons. We wanted to ensure that that choice was consistent over time, and especially because the day that I saw her, she had just gone through some pretty major medical events, including she had a major spine surgery, a decompression and a fusion. She had gone through some oxygen desaturation overnight, so was not breathing as well. Her heart rate was up, all of which then led to her being what we call delirious. She was confused overnight to the point where she asked her nurse, "Am I delirious?" And she was also experiencing some visual hallucinations. So that was one of the reasons why I was called in, to make sure that she was able to make that decision to change her healthcare proxy. And then in addition, the team had also voiced, concerns that she had come in after a reported suicide attempt. And so making sure that she was able to make that decision of sound mind. And so we actually waited until the next day when she could be reassessed. At that point, her delirium had cleared, and she was continuing to make that consistent choice to change her healthcare proxy to her parents.
And in fact, you noted in the medical records that the hallucinations were part of an issue with oxygen.
It could be. That could be one of the reasons. Delirium is usually due to a variety of different medical reasons, and oxygen desaturation could be one of them. She had also just recently had anesthesia related to a surgery that she had on her spine, so that could be another reason. And then her heart rate was also actually quite elevated, so that could be another reason.
Is it common for patients who are just coming off of anesthesia from surgery, who have an issue with oxygen and other medical issues that you described, to have visual hallucinations?
They can. It's not that everybody does, but they can. And delirium can be quite common after surgery, and particularly anesthesia.
And those hallucinations that she was having, those were resolved by the next day. They were over by the next day, correct?
That's correct.
And her choice to change her healthcare proxy to her parents was consistent the following day, correct?
That's right.
You also talked about the patient has to understand the risks and benefits of the decision, correct?
That's correct.
How do you make sure the patient understands that?
Yeah, so one of the things we do is really ask patients to take us through their thought process of why they're making that decision and what led to them making that decision at that moment in time. So we're able to kind of see their thought process and ensure that they're understanding, what it means to remove one person and add another.
And what was Ms. Clancy's thought process in explaining that to you?
Yeah, she was saying that her parents are quite supportive to her, and that she was thinking that she would have to change her healthcare proxy from her husband to somebody else. And we didn't necessarily go into the reasons as to, why she would have to change it, but she explained that she was very close with her parents. They would see each other frequently, given that they lived in close geographic proximity, and that she felt that they were very supportive to her and would have her best interests in mind should we need to invoke the healthcare proxy, or that if she couldn't make her own medical decisions.
So was there a concern on her part that her husband wouldn't have her best interests in mind at that point in time?
Sustained.
You also talked about the patient. You have to make sure the patient's thinking about the information rationally. How do you go about doing that?
Yeah, so one of the things we do is really ensure that the patient understands the situation and, all of the kind of parts around it. So this comes into play much more when it's about a specific medical intervention, like an invasive medical procedure, or something like an amputation or a surgery. With a healthcare proxy, one of the things you want to make sure is that the person that they want to change their healthcare proxy to or appoint as their healthcare proxy makes sense in the context of their life. Ms. Clancy was able to talk about how her parents were quite involved in her life. And so that's one of the things that we would assess.
Okay. And then the last thing was making sure the patient understands the risk if the change doesn't happen. Mm-hmm. Did you go over that with Ms. Clancy, and how did you do that?
Yeah, I did go over that with her. We talked a little bit about how it could mean that she would not have a healthcare proxy were she not to appoint her parents. And so we went through that, it's always in healthcare, we always talk about how it's great to have a healthcare proxy just in case you become unable to make medical decisions, and who would you want that to be?
And during this conversation with the defendant going over all these points, did you ever have difficulty understanding her?
I did not.
Did she ever appear to have difficulty understanding you?
So the first day when I saw her on January 29th, she described herself as feeling confused, and I definitely witnessed that as well. We went through a bedside cognitive evaluation, and she definitely made some mistakes on some of the cognitive evaluation. Therefore, I did diagnose her at that time with delirium.
And then she was re-evaluated the following day, and there were no issues with her understanding, and the delirium was gone, correct?
That's correct.
And were you aware during this evaluation that Ms. Clancy did not have a brain injury?
I'm sorry, can you repeat the question?
Were you aware that Ms. Clancy did not have a brain injury at that time?
One of the things that we look at is any kind of relevant medical information that might be available to us. And I noticed that her Glasgow Coma Scale, when she was transferred to Brigham and Women's Hospital, was a 10, which would indicate that she could potentially have had a moderate brain injury. But I don't recall thinking about whether, specifically whether she had a brain injury.
Were you aware that a CAT scan was done, page 110 of the records, and on the CAT scan, the impression was no acute intracranial findings, so no brain injury.
So you can.
CAT scan, correct?
I did review the head imaging that was available at the time. You can have a normal CAT scan and still have a brain injury.
Were you aware that she had multiple CAT scans that showed no bleeding in the brain, no skull fractures, no injuries, just visible injuries whatsoever?
I'm sorry, but can you repeat the question?
Were you aware that she had multiple CAT scans at South Shore Hospital and at Brigham and Women's that showed no skull fractures, no intracranial bleeding, no hemorrhaging, no visible damage whatsoever?
Yes.
Okay. And were you aware that she was evaluated at South Shore Hospital and at the Brigham, and she had no external injuries on her head either?
Yes.
Now, she was allowed to change her healthcare proxy to her parents, correct?
That's correct.
So if someone was had an injury, a brain injury, to the point where they didn't know what was going on, or they were having trouble processing or thinking, they wouldn't be allowed to change their healthcare proxy, correct?
It depends to what extent. Most patients that have either a head injury or severe mental illness, let's say, just anything going on with the brain, retain the ability to make most medical decisions. And we think about changing healthcare proxies as a pretty low risk decision. As I mentioned before, something like an amputation or a major surgery, invasive procedure is something that we would hold somebody to a higher bar. But a healthcare proxy is a pretty low risk, especially if it makes sense in terms of who they want to change it to.
And when was her Glasgow score 10?
I believe it was as she was being transferred from the outside hospital to Brigham and Women's.
And you're seeing her several days later, correct?
Correct.
And so when she was transferred from the outside hospital to Brigham, she was unconscious, correct?
I believe so.
Okay. So now she's conscious, correct?
That's correct.
And when she was transferred from the outside hospital to Brigham, she wasn't communicating or speaking or opening her eyes on her own, correct?
That's what the report said. I was not there at that time, but the notes that I read, that's correct.
So when you're speaking to her a couple days later, she's opening her eyes, she's communicating, she's responsive, she's interacting, correct?
Yes.
So it's fair to say that her Glasgow score would be higher than the 10 when you were speaking to her, correct?
Yes.
Now, you did a mental status examination of her while you were doing this evaluation about her decision-making capacity, correct?
Yes.
And it's fair to say under mood you listed okay?
Yes.
That you listed her thought process as organized, goal-directed. Is that correct?
Yes.
You asked her if she was having hallucinations or delusions, and she, other than those initial ones the first day, she denied those?
During my evaluation, yes.
And she also denied suicidal intent and homicidal intent, correct?
Yes.
And you listed her insight and judgment as fair, correct?
Yes.
Her behavior was calm and cooperative?
Yes.
And you didn't see anything about her behavior that would indicate to you that she was responding to some type of voices or hallucination that you couldn't see?
At that moment, no. But as I mentioned, I did speak with the nurse beforehand, and Ms. Clancy was able to report to me that she reported visual hallucinations overnight.
Overnight after surgery?
That's right.
Okay. And then never again?
Not during my evaluation.
Okay. And did you speak to Ms. Clancy again on February 19th, 2023?
Yes.
And was the purpose for that to prepare her for a transition from Brigham and Women's to Spalding Rehabilitation?
That was one of the reasons.
Okay. And what were the other reasons?
So it was an ongoing safety evaluation, ongoing evaluation of psychiatric safety risk, as well as medication evaluation to determine if her medications were at the right level, the right dosage, and that she was on the right medications, and then just ongoing evaluation in terms of kind of her mental status.
And during that meeting, she denied suicidal intent, correct?
That's correct.
She denied homicidal intent, correct? She denied having auditory or visual hallucinations, correct?
Yes.
She reported her mood as okay, is that correct?
Yes.
And she told you she was looking forward to moving to Spalding, correct?
Yes.
She also denied any confusion or disorientation, is that correct?
Yes.
And again, you described her mood as okay on that day?
Yes.
And you described her as future-oriented on that day?
Yes.
And then you spoke to her again on February 21st, 2023, is that correct?
Yes.
And on that day, is this the same purpose that you just described, getting her ready, assessing her mental status and getting her ready to transfer to Spalding?
Yes.
Okay. And during that time, you wrote that the patient reported feeling down about her current situation, her paralysis, and the events leading up to her hospitalization. Is that correct?
Yes.
And you also noted that she said her thoughts about what she had done were not constant throughout the day, correct?
Correct.
So she wasn't thinking about killing her children throughout the day, every day, correct?
Correct.
And she said she had no suicidal intent, no homicidal intent, correct?
Correct.
No auditory or visual hallucinations, correct?
Correct.
You also write no PI. What does PI stand for?
Paranoid ideation.
And there was none of that either.
Correct.
You also made a note, notes low mood today in the context of her physical and legal situation, but does not currently meet criteria for major depressive episode. Is that correct?
Yes.
So her focus seemed to be on her physical and legal situation, but being hopeful about moving on to Spalding.
Okay. Could I see counsel?
And so her focus at that time appeared to be her physical situation, her legal situation, and looking forward to going to Spalding Rehab.
Yes.
And then your last visit with her was February 22nd, 2023, correct?
Yes.
And again, she indicated she was hopeful about treatment at Spalding.
Yes.
She was future-oriented.
Yes.
And she denied suicidal ideation, homicidal ideation.
Yes.
She denied audio hallucination, visual hallucination, and anything else of that nature.
Yes.
Thank you.
Attorney Reddington.
Afternoon. So, Doctor, from your testimony, and correct me if I'm wrong, was she, to your opinion and your experience, an honest patient telling you what her symptoms were, if any?
Objection.
That's an evaluation in the psychiatric.
I'll allow that question.
Yes.
In other words, she didn't go off and try to exaggerate to you and say, I'm seeing visions and I'm hearing voices and I'm suicidally ideated and I'm homicidally ideated. She didn't say any of those things to you, did she?
No.
She actually denied them, right?
Correct.
So this is not, in your opinion, someone who was trying to exaggerate her conditions for some legal reason, correct?
No.
And you obviously were in close contact with her for about a month, right?
That's right.
Just a couple of questions. Counsel asked you whether or not, and I think it may have been in the beginning in January, that you had difficulty understanding her. Obviously, after removing the tubes and everything else, you're able to talk with her, correct?
Correct.
And you knew that one of the concerns, if you will, was postpartum issues. You knew that, right?
Yes.
And in your experience as a psychiatrist, you're familiar with the concept of postpartum psychosis, correct?
Yes.
And you know that people can communicate and plan and act on plans, even if they're in the middle of a psychosis, right?
Yes.
You don't have to be drooling and stumbling and unable to walk and talk to be in a psychosis, do you?
No.
So in other words, a person can be in a psychosis and can communicate to friends, family, people, talk, correct? So you didn't, as counsel asked, you didn't have any difficulty understanding her. She wasn't slurring her words or anything like that when she was able to talk.
Right.
Okay. One of the things that when she was admitted, and then without going through, I'm not going to go through all the stuff we've already talked about with the medical condition and everything else, you indicated that she was very, very ill, correct?
Correct.
Did she appear to be cooperative to you when you would interact with her?
Yes.
As a doctor, as a psychiatrist, you're familiar with bipolar, the concept of a bipolar diagnosis, correct?
Correct.
Can you tell me what bipolar means?
Yeah, so bipolar disorder is a mood disorder, categorized as a mood disorder, where patients have distinct depressive episodes, as well as, depending on the type of bipolar disorder, either hypomanic episodes or manic episodes, to the point where they don't sleep for days, they still have lots of energy, there's this decreased need for sleep, there could be irritability, there can be impulsiveness, racing thoughts. A lot of patients describe that they're out of control of their behavior, and then severe episodes can also include psychosis.
And in reference to bipolar, as you were referring to, when somebody is hypomanic, what does hypomanic mean?
Yeah, it's a lesser degree of mania. So when patients are hypomanic, they don't always experience things like psychosis, but they might experience some of the other symptoms that I described, including racing thoughts, kind of moving too quickly, talking too quickly, being irritable.
And as it relates to the hypomania, would that include things such as somebody who is getting up early in the morning and exercising, or cleaning out their house, or selling their property out of a garage and having difficulty sleeping, and they're awake all night?
Yes.
As a psychiatrist, one of the things you were concerned about when you were first started to deal with her, as well as when you were releasing her, if you will, is the medication that she had on board, so to speak, when she came into the hospital, right?
Yes.
Do you remember, and I know it's difficult to recall offhand, but do you recall the medications that she was actually under from purposes of taking her blood when it was tested?
When she first came to the hospital?
Yeah, if you know.
I believe her medication list for, previous to the incident, she was on amitriptyline, diazepam. I believe she was also on prescribed lorazepam, and there may have been one other.
Okay. So looking at that, if I tell you that there was a toxicology report done on her as of January 24th by way of taking her blood, you're familiar with that, right, when they analyze for toxicology? And toxicology obviously would tell us what the medications, if any, what type of drugs she had on board, booze, cocaine, anything, right?
Yes.
And you're aware that the toxicology report, as well as the report from the Department of State Police, as well as the NMS laboratory, which would be in Pennsylvania. So that's an international or a national respected laboratory, isn't it? The NMS lab, if you know?
I don't know.
Okay. But you know that they did take her blood, they did test her blood, and it was at the State Police laboratory as well as any other labs that tested it, right?
Yes, I believe I found that out later. I did not know that the first time I saw her because those labs take a little bit of time to come back.
And you treated her for about a month, so you were pretty
That's
close
right.
to her and got to know her quite well?
Yes.
Would you agree with me that one of the things that her blood reflected or that she was on was trazodone?
Yes.
And can you tell me what trazodone is?
Yeah, trazodone is an antidepressant medication. It's more often utilized as a sleep aid because of one of the side effects is sedation. And so patients that are often having difficulty sleeping are placed on trazodone.
And is trazodone, does that share some of the qualities of what are referred to as SSRIs, even though it's not an SSRI? It shares similar qualities.
Yes.
Can you tell me what SSRI means?
Yeah, so that's a selective serotonin reuptake inhibitor, and it's a class of medications that are antidepressants.
And the SSRIs, that would also include Zoloft, for example?
Correct.
Would also include Prozac, for example?
Yes.
Are you, as a psychiatrist, aware that Zoloft and or SSRI Prozac should not be prescribed to a patient who has bipolar?
Yeah, it can be prescribed. Oftentimes it's prescribed together with another medication that can be protective because patients with bipolar disorder may be experiencing depression, and so they may be prescribed an antidepressant, but along with another medication that what we call protective.
And in reference to the SSRIs, the selective serotonin reuptake inhibitor, what does that mean, selective serotonin reuptake inhibitor? What does that mean?
Yeah, so oftentimes in depression, patients are kind of lacking serotonin in the spaces in their brain that helps.
Can I interrupt you? What is serotonin?
Yeah, serotonin is a neurotransmitter, so it's a hormone in the brain that works on the brain. It works in other areas in the body as well, but for these purposes, it works in the brain at nerve endings throughout the body. And that neurotransmitter helps with things like mood regulation. For patients with depression, they're often lacking kind of that ability to have enough serotonin in those spaces. And so a selective serotonin reuptake inhibitor prevents serotonin being kind of sucked back into the cell. So it allows for serotonin to be more available.
And what is an SSAI? What does that mean? Antagonist, selective serotonin antagonist.
So those are medications that kind of do the opposite.
Okay. And you knew, as a psychiatrist, at least looking at her history, you knew that she had been seeing psychiatrists immediately prior to her suicide attempt, correct?
Correct.
And you knew that she had been prescribed a number of drugs by these various psychiatrists, correct?
Correct.
And to your knowledge, was she prescribed diazepam?
Yes.
Valium? Was she prescribed buspirone, otherwise known as Vanspar?
Yes.
How about Wellbutrin?
Yes.
And what is Wellbutrin? Is that an antidepressant?
It is an antidepressant.
Hydroxyzine. What is hydroxyzine?
It can be used for a number of reasons, but for psychiatric purposes, it's often used as an anti-anxiety medication.
And Klonopin.
Yes.
Is hydroxyzine, is that a, strike that. Klonopin, that's a benzodiazepam, right?
That's correct.
And then lamotrigine.
Yep, lamotrigine.
Lamotrigine, sorry.
Yes.
What type of medication is that? Is that a mood stabilizer?
It is, yeah. It's also an anti-seizure medication, but in the psychiatric realm, it's used as a mood stabilizer.
And then we talked about Prozac, that's an SSRI, correct?
Correct.
And what's Remeron?
Also an antidepressant.
So in addition to all of the drugs that I had mentioned, she was also prescribed Remeron, correct?
Correct.
She was also prescribed Seroquel or quetiapine.
Yeah, quetiapine, yes.
Quetiapine, okay. And what is Seroquel?
So Seroquel is an antipsychotic medication.
And she was prescribed, as we already talked, trazodone. Was she also prescribed amitriptyline?
Yes.
What is amitriptyline?
Amitriptyline is one of the older antidepressants. It's a tricyclic antidepressant that can often be used to help with sleep, but also mood.
And Ambien, correct?
Correct.
And Zolpidem.
Yep, Zolpidem is the generic name of Ambien.
Oh, okay. Some of these drugs, they also have what's called a suicide warning or a black box warning. Isn't that right?
Yes.
Can you tell me what that means?
Yeah. So in studies that have been done, some of them show that especially after starting an antidepressant, it can increase someone's risk of suicidality. Many of those studies showed that it was mostly in adolescents and young adults, but it can happen in adults as well.
And Celexa was also a drug. Is that an SSRI too?
It is.
And all of these drugs that we just went through were all prescribed from September, end of September till January.
Yes, September 2022.
4-month period.
Yes.
It's an awful lot of drugs to be prescribed in 4 months, isn't it?
Objection.
Sustained.
Thank you.
Thank you.
Commonwealth redirect?
Yes. Doctor, all those drugs that defense counsel just listed, you're aware she wasn't on all of those drugs at the same time, correct?
Correct.
And did you know that many of those drugs she took a very small amount of? Some she didn't take any pills at all?
I was not aware of that.
For Buspar, which is one of the ones he mentioned, were you aware the first prescription she only took 2 pills out of that bottle?
I was not aware.
Were you aware the second prescription a month or so later for Buspar, she took 0 pills out of that bottle?
I was not aware.
So where are you getting this information about what she was on and when?
Yeah, so one of the things that we do is try to collect as much information as we can during our assessments. And so we look through the record in terms of what was prescribed. We also talk with other providers as to what they prescribe. But in the context of the assessments that we were doing, it did not require us to determine, what exactly she had been on before, because we were using a different set of medications to treat something, different symptoms that she was experiencing.
Okay. So you really have no idea what she was taking or when? You just know what was prescribed?
I know what was prescribed, and then we were also getting reports of what was being taken, what wasn't being taken. But
From the defendant?
Correct.
Okay. So she's reporting to you that she took those medications, but you'd be surprised to know that at least one of them, 0 pills were taken.
I don't think I'm surprised, no.
Okay. And you talked about prescription and what she was taking. Were you aware that in the time frame just prior to her being admitted to the hospital, she was only prescribed trazodone, Valium, and amitriptyline, just 3 medications?
Yes, I was aware.
And you were asked about mania and exercising and cleaning out your garage and selling your belongings could be signs of mania, correct?
Correct.
But there are people who just exercise every day and they're not manic, correct?
Correct.
And there are people who have a messy garage and have accumulated a lot of junk and decide to clean out the garage that aren't manic, correct?
Correct.
And in fact, if someone is manic and attempts to do one of those tasks like cleaning out a garage, it's usually in a disorganized way, and oftentimes they don't finish the task, correct?
Sometimes.
So if someone approaches a task like cleaning out the garage by organizing with another party, organizing the belongings, separating them into keep, sell, throw out, that's pretty organized behavior, correct?
Correct.
And if someone sells belongings that they no longer need, that's not necessarily a sign of mania, correct?
Correct.
That's more if they're selling their stove and then they have nothing to cook with, correct?
Correct.
So if they're selling junk in their garage that they no longer need, that's not necessarily manic, correct?
Not necessarily.
Thank you.
Mr. Rington?
So if the person, as counsel said, they're exercising every day and they have a messy garage, that obviously would not be indicative of hypomania, would it?
Probably
A
not.
normal person could have, as counsel said it. How about a person that at the same time can't sleep because the insomnia is so bad they go 48 hours without sleep? Is that something to be considered in the whole evaluation?
Yes.
How about the fact of a person saying that my brain is broken and that they can't concentrate, they can't think. Is that something that the person you would consider in conjunction with the messy garage and the exercise?
Yes.
Thoughts of hurting themselves, suicidal ideation, that's something that's important to evaluate?
Yes.
Homicidal ideation, telling your husband that you're having thoughts about hurting your children, that's something you consider, isn't it?
Yes.
In reference to counsel's comment about just 3 medications that she was on prior to trying to commit suicide, you're not aware of the doctors telling her to discontinue this medication, start a new medication, go on to a different medication, depending on the doctor. You're not aware of that, right?
No.
And finally, if you know, did she sign a DNR, do not resuscitate?
She asked to the day after the first evaluation that I did of her, which was the capacity assessment to change her healthcare proxy. But in the context of her reporting a serious suicide attempt, we did not change her code status. We continued to chat with her about that, and she ultimately came to the conclusion that it made sense to make sure that her mental health was stable before she considered her code status.
Okay, but her initial reaction or her conversations with you all was that she wanted to have a do not resuscitate status.
Correct.
Thank you.
Como?
Nothing further.
All right, thank you, Doctor.
Thank you, Your Honor.
All right, members of the jury, we're going to take the afternoon recess at this point. So I'm going to ask you to go back to your room, and then we'll come back here approximately 2 o'clock. Okay?
All right. Sure. So the notebooks placed on the chairs, please.
Counsel, anything we need to address before the break?
No, Your Honor.
No.
All right, so we'll be in recess till about 2 o'clock. Thank you.
Thank you.